This conference will now be recorded.
Reproduction. So what is endocrinology? Can anyone tell the answer for these questions? What is endocrinology? Come up fast with the answers. Roll number 15. Is roll number 15 present? జ్యోతి ప్రకాష్ వినపడుతుందా నీకు? అందరికీ వినపడుతుందా? రోల్ నెంబర్ 14. Who is roll number 14?
Yes, ma'am.
What is endocrinology? Tell something, na?
And ఇప్పుడు 10 షార్ట్ లిస్ట్ చేశారు, ఒక 10 పోస్టర్స్. అది 1, 2, 3, 4 అని పెట్టారు, పేర్లు ఏం రివీల్ చేయకుండా. అండ్ జడ్జెస్ కి ఓటింగ్ చేసేయమన్నారు. సో అలాగే దే డిక్లేర్ ద విన్నర్స్. సో ఇది కూడా అలానే చెయ్యొచ్చు. ఒక్క నిమిషం ఆగు.
Who is that?
This conference will now be recorded.
So today's class is on endocrinology in relation to reproduction. So we are not going to talk about endocrinology in detail. We are going to talk about endocrinology in relation to reproduction. That is more about placental hormones. Endocrinology is a study of endocrine glands and the hormones which are going to get released from endocrine glands. So coming to the introduction, like where all this endocrine system is actually necessary during this follicular maturation, fertilization, ovulation, fertilization, and coming to pregnancy, and followed by puerperium and lactation. So first step where the endocrine system is actually necessary is maturation of Graafian follicle, ovulation, and maintenance of corpus luteum. So all this follicular development, ovulation, and maintenance of corpus luteum is actually under the control of hypothalamus, pituitary, and ovarian system. So this system of endocrine system and their hormones which are released from hypothalamus, pituitary, and ovaries are actually necessary for maturation of the follicle into Graafian follicle, and after reaching the size of 20 mm, then it gets ovulated, and finally the corpus luteum which is going to get maintained. And the second one is placental transfer of pituitary ovarian function. First, this hypothalamo-pituitary ovarian function, the hormones which are released from pituitary and ovary will take up the function of maintenance of corpus luteum, which is going to get transferred to the placenta, to the developing placenta if the ovum is getting fertilized. So that we will call it as luteoplacental transfer. So the second one is placental transfer of pituitary ovarian function. The third one is the physiological changes of the endocrine glands which are going to get happen during pregnancy. So pregnancy is a state where so many physiological changes are going to happen, among which we are going to deal about endocrine gland physiological changes. And the fourth one is during labor, where oxytocin plays a major role in during onset and maintenance of the labor. And finally the lactation, where prolactin is the major hormone which is responsible for lactation. So these are the 5 main areas where we are dealing with endocrine and hormones in respect to reproduction. So coming to placental endocrinology, about 6 to 8 weeks, this transfer of functions from pituitary and ovarian, that is from the corpus luteum to the placenta, is happens. So where the corpus luteum takes the function of secretion of progesterone up to 6 to 8 weeks, which is going to get transferred to the placenta, and placenta acts as a temporary and as a new endocrine organ, and it is a powerhouse of the hormone production during the reproductive period. So up to 6 to 8 weeks before placental development, the corpus luteum, which is the luteal cells of the corpus luteum, secretes the progesterone, which actually maintains the pregnancy. Later on, this placenta will take up this function, and placenta is the main powerhouse of the hormone production during reproductive period, and it's a temporary organ, as you all know. So what are the main placental hormones? Usually hormones are divided into peptide hormones and steroid hormones. Peptide means protein part, steroid means fat part. So peptide hormones and steroid hormones. So the major hormones which are going to get released from placenta are hypothalamic like hormones, that is releasing type of hormones, that is CRH, the corticotropin releasing hormone, gonadotropin releasing hormone, thyrotropin releasing hormone, and growth hormone releasing hormone. All these releasing hormones are hypothalamic like hormones, where they are going to get secreted from cytotrophoblast and syncytiotrophoblast of the growing embryo of the placenta. And the second one are the pituitary like hormones. This is ACTH, human chorionic gonadotropin, human chorionic thyrotropin, and human placental lactogen. This is from syncytiotrophoblast of the placenta. So other pregnancy associated proteins like pregnancy specific beta glycoprotein, pregnancy associated plasma protein A are going to get secreted from syncytiotrophoblast, and relaxin from corpus luteum, decidua, and placenta. Prolactin hormone from decidua, ANP, atrial natriuretic peptide from atrial myocyte, and early pregnancy factor from activated platelets and ovaries. So the next one is growth hormones. There are several growth hormones which are released from syncytiotrophoblast like inhibin, activin, transforming growth factor beta, insulin growth factor 1 and 2, epidermal growth factor. And coming to the major part of steroid hormones which are actually necessary in reproduction are estrogens, progesterone, and cortisol. Estrogens, the primary estrogen which is important during reproductive period, that is during pregnancy, is estriol. Estrogens are of three types like estrone, estradiol, and estriol. During pregnancy, estriol forms the major portion which is secreted from fetoplacental unit, and progesterone before 6 weeks, as we have already learned that from corpus luteum, and thereafter it is getting transferred to the placenta, where we call it as luteoplacental transfer, and cortisol from decidua and adrenal glands. So these are the various hormones, both peptide and steroid hormones, and their origin, and their cell of origin, the cytochemical origin from where it is getting released. So among which we are going to talk about the major peptide hormones like human chorionic gonadotropin, human placental lactogen, where HCG, it's a glycoprotein with molecular weight of 36,000 to 40,000 Daltons. It is chemically and functionally similar to luteinizing hormone, which is released from pituitary. So it is similar to luteinizing hormone, and it also binds to luteinizing hormone like receptor. So it consists of a hormone non-specific two parts, that is alpha and beta. This alpha part contains 92 amino acids, which is a non-specific part because it is having a similar structure like other hormones like LH, FSH, and TSH. And the second part is a specific beta part. So this beta part is composed of 145 amino acids, which is very specific for HCG. So the alpha subunit is biochemically similar to LH, FSH, and TSH, as I have already said, whereas the beta subunit, it is relatively unique to HCG, and this is the beta subunit where we actually measure and actually go for a qualitative and quantitative analysis for diagnosing the presence of HCG hormone. So it's a glycoprotein with molecular weight of 36,000 to 40,000 Daltons, which is similar to luteinizing hormone from pituitary gland. It consists of two parts, alpha and beta. Alpha consists of 92 amino acids, which is non-specific because it has a similar structure with, it shares a similar structure with other hormones like LH, FSH, and TSH. And it is having the second part, the beta part, which is a hormone specific part, where we use this beta HCG as qualitative and quantitative, in qualitative and quantitative analysis of diagnosing this hormone. So coming to plasma life of HCG, it's only 36 hours, and usually it is detected in maternal serum or urine by 8 to 10 days post fertilization. That is after 14 days, like 8 to 10 days post fertilization, one can detect this serum or urine beta HCG. And HCG usually it will increase in level up to 10 weeks, going to its peak levels up to 10 weeks. Then it have a plateau, and then slowly it will decrease and will maintain in the same range up to 32 weeks of gestation. So when it is growing, it is having a specific doubling time. Doubling time means this now if HCG value is some X, it is going to get doubled for every 1.4 to 2 days. You just remember 48 hours or 2 days, where this value is actually necessary to diagnose a viable pregnancy and to differentiate an ectopic or abortion. So this doubling time we use for diagnosing a viable pregnancy and to differentiate a ectopic from a viable intrauterine gestation. So doubling time of HCG is 2 days in the early pregnancy. So usually when you see these blood and urine values, usually we go for a qualitative analysis. Qualitative analysis means just presence or absence of this hormone. If you go for a quantitative analysis, that is if you want the level of HCG, how much of HCG, how much amount of HCG is present in the serum, then you have to go for a quantitative analysis. If you go for a quantitative analysis, usually this HCG will have a trend. It will increase, it will double for every 48 hours, and it will peak, it will go to a peak range by 70 days of pregnancy, where the concentration or the value becomes 100 to 200 international units per ml. You just mention these units, international units per ml. If it is international units per liter, then it is 1 lakh to 2 lakhs. So after that, slowly it falls, reaching to only 10 to 20 international units per ml by 100 to 130 days. Thereafter, it remains constant throughout the pregnancy with a secondary peak at 32 weeks of gestation. So slowly it will increase with a doubling rate of 2 days, and it will reach a peak of 100 to 200 international units per ml by 70 days. And slowly it falls, reaching to 10 to 20 international units per ml by 130 days. And after that, it follows a peak value, a constant value, a plateau range, and again it has a secondary peak at 32 weeks of gestation. So when it is going to get disappeared, so for a viable pregnancy after termination, usually following delivery, 2 weeks following delivery, this HCG disappears. For an abortion, it will take 6 weeks for the HCG to get disappeared. So what is the significance of HCG? When are you going to measure this HCG values, either qualitatively or quantitatively? Elevated HCG levels are seen in multiple pregnancy, erythroblastosis fetalis, molar pregnancy, and Down syndrome. The levels are lower if the levels are not up to the mark. If it is not growing up to the mark, it is then you have to suspect ectopic pregnancy, missed abortion, and Edwards syndrome. So this is the significance of human chorionic gonadotropin. So finally, the clinical application, where are you going to apply this HCG values? First, to diagnose the pregnancy. So when a woman is getting pregnant, then you have to go for a UPT, urine pregnancy test, where you can qualitatively check for a beta HCG, presence or absence of beta HCG in urine of a pregnant woman. And if you suspect an ectopic pregnancy, you will go for a quantitative analysis of beta HCG in the serum. So you will check beta HCG today, and after 48 hours you will check if the doubling rate is adequate. That is, if there is an increase of more than 66%, then it is a viable pregnancy. If the increase is less than 66% after 48 hours, then you have to suspect an ectopic pregnancy. And you can apply this beta HCG values in the follow-up of molar pregnancy. There is a molar pregnancy. After evacuation, you have to check beta HCG values serially, so that you can diagnose a invasive mole or a gestational trophoblastic neoplasia at the earliest. And it is also used in screening of Down syndrome, where its value is elevated. In this first trimester, you can advise a double marker or a dual marker, which consists of beta HCG along with pregnancy associated plasma protein A, where beta HCG is increased in Down syndrome. So this is the clinical application where we are using this beta HCG values. Diagnosis of pregnancy when you suspect an ectopic pregnancy, follow-up of a molar pregnancy, and screening of Down syndrome. So there are some functions for this HCG. So what are the major functions of human chorionic gonadotropin? The major function is maintenance of corpus luteum. It's rescue and maintenance of corpus luteum till 6 weeks of pregnancy until placenta is going to take over. HCG stimulates the Leydig cells of the male fetus. If the fetus is male, the Leydig cells of the testis of male fetus is stimulated by HCG, where testosterone is produced. So it is thus indirectly involved in the development of male external genitalia. It also has an immunosuppressive activity. See, when a pregnant woman is carrying a fetus of even paternal origin, then the fetus is going to be a foreign body for the pregnant woman. So there is a chances of immunorejection reaction to happen. So this HCG acts as an immunosuppressive. It has an immunosuppressive activity which inhibit the maternal process of immunorejection of the fetus as a homograft. So it stimulates both adrenaline and placental steroidogenesis. So steroidogenesis is from adrenaline gland and placenta. So it stimulates both the placenta and adrenaline gland for steroidogenesis. And it also stimulates maternal thyroid because of its thyrotropic activity. Because it is having a similar alpha chain which resembles the TSH. So it also has a thyrotropic activity. It will stimulate the thyroid gland as well. It promotes the secretion of relaxin from the corpus luteum. These are the various functions of HCG. Coming to the second hormone, which is a peptide hormone as well. This is human placental lactogen. This is also known as human chorionic somatomamotropin. So human placental lactogen is also called as human chorionic somatomamotropin. This hormone is chemically and immunologically similar to prolactin and growth hormone. So human placental lactogen is first detected in the maternal serum by 3rd week of gestation. HCG is first detected by 8 to 9 days post fertilization, and human placental lactogen is first detected during the 3rd week of gestation. And after its first detection, this level is going to rise progressively from 5 to 25 micrograms per milliliter until about 36 weeks. But HCG is not having this progressive increase in quantity. HCG is having a peak at 70 days, and after that there is a small fall, and after that it plateaus, and again a secondary peak at 32 weeks of gestation. But human placental lactogen is having a progressive rise up until 36 weeks of gestation. The plasma concentration of human placental lactogen is actually proportional to the placental mass. So what are the various functions of human placental lactogen? It is having an anti-insulin like action. So it actually antagonizes the insulin actions. So human placental lactogen, it promotes the transfer of glucose and amino acids to the fetus. So it promotes the maximum amount of transfer of glucose and amino acid to the fetus. It is also having a potent angiogenic feature which helps in development of fetal vasculature, and it promotes the growth of breast for lactation as well. So major function is anti-insulin like action and angiogenic hormone which helps in development of fetal vasculature. Third one is pregnancy specific beta-1 glycoprotein. It is produced by trophoblastic cells, can be detected in maternal serum by 18 to 20 days after ovulation. Its major function is a immunosuppressor. The next one is early pregnancy factor. It is a protein hormone produced by activated platelets, as we've already discussed in the chart prior, and other maternal tissues like ovaries. It is detectable in the circulation by 6 to 24 hours after conception. It is also having an immunosuppressant action. So these growth factors, they have a varied functions including immunosuppressive paracrine. Paracrine means when it is secreted, it is going to act on the cells which are nearby it, and it is also having a steroidogenic action. This pregnancy associated plasma protein is secreted by syncytiotrophoblasts, and it is also having an immunosuppressive action. And this pregnancy associated plasma protein usually we will use as a double marker, as I've already said, for diagnosis of Down syndrome, double marker in the first trimester of during the first trimester in the pregnancy, whose low levels is associated with increased risk of preeclampsia and IUGR, and even Down syndrome as well. So coming to the steroidal hormones, So first we have mentioned about peptide hormones, among which human chorionic gonadotropin and human placental lactation are very important. And coming to the second one is the steroidal hormones, where estrogen and progesterone are the major steroidal hormones. So first one is estrogen. In late pregnancy, the qualitatively estriol, as I have already said, during pregnancy, estriol levels are more important, and among the three estrogens, this is the major estrogen which is seen in the serum in late pregnancy. So the site of production is syncytial trophoblast, as we have already seen, and placenta is an incomplete becomes an incomplete endocrine organ because it is not having the precursors. Precursors means from where it is going to get generated. So it has no capability of independent steroidogenesis. For steroidogenesis, this placenta should depend on both maternal and fetal counterparts. So this diagram, it shows the cholesterol, which is the actual precursor for steroidogenesis, is absent in placental tissue, where the cholesterol from maternal and fetal tissues is converted into steroids, which is getting transferred to the placenta. If you can see here from the fetal side, cholesterol is going to get transferred into pregnenolone sulfate in the adrenalins, and finally into dehydroepiandrosterone sulfate in adrenal and liver, and followed by its hydroxylation in the liver, which forms 16 alpha hydroxy dehydroepiandrosterone sulfate. This 16 alpha hydroxy dehydroepiandrosterone sulfate, it is getting transferred into placenta, where it is converted to estriol by the action of sulfatase, 3-beta hydroxysteroid dehydrogenase, and aromatase. So remember, from the fetal tissues, the 16 alpha hydroxy dehydroepiandrosterone sulfate is transferred to placenta, and with the action of various enzymes like sulfatase, aromatase, and 3-beta hydroxysteroid dehydrogenase, it is converted to estriol, which forms the major part of estrogen in the pregnant women. So this is the synthesis of estriol. So estriol is first detected at 9 weeks of gestation. It gradually increases from 0.05 nanograms per ml to 30 nanograms per ml at term. So where you see this low estriol levels are fetal death, fetal anomalies, molar pregnancy, and placental sulfatase and aromatase deficiency. You can see all the causes of low estriol levels are poor placentation and poor which comprises of low estriol level signifies the poor formation or the fetal death and fetal anomalies, all this having a negative impact on the healthy pregnancy. So these are the various reasons: death, anomalies, molar pregnancy, and enzyme deficiencies like placental sulfatase and aromatase causes low estriol levels. So coming to the second steroidal hormone, progesterone. Before 6 weeks, as we have already know, progesterone is secreted from corpus luteum. And following the development of trophoblast, progesterone is synthesized and secreted in increasing amount from the placenta itself after 6 weeks. So the precursors from fetal origin are not necessary, as we have seen in estrogen production, and daily production of progesterone is 250 milligrams in a singleton pregnancy. And after delivery, the plasma progesterone levels, they decreases rapidly, and usually they are not detectable after 24 hours after delivery. So the significance of progesterone is low progesterone levels are seen in ectopic pregnancy and miscarriage, and high progesterone levels are seen in high daddy form mole and RH isoimmunization. So low estriol levels, fetal death, anomalies, and enzyme deficiencies, and low progesterone in ectopic and abortions. So the functions of steroid hormones are coming to estrogen. It causes hypertrophy and hyperplasia of uterine myometrium, which is actually necessary, which is a physiological change in the uterus for accommodating the growing fetus and increasing the accommodation capacity and blood flow to the uterus, which is actually necessary for the growing fetus. So these functions are due to estrogens. And progesterones, along with estrogen, it stimulates the growth of uterus and causes the decidual changes of the endometrium. Decidual changes of endometrium, the pregnant endometrium, usually we call it as decidua, and this is actually required for the implantation, and it inhibits the myometrial contraction. So it actually supports the pregnancy. It will increase the chances of implantation, and it will inhibit the myometrial contraction, thereby it maintains a pregnancy. So what are the actions of steroid hormones on breast? On breast, the hypertrophy and proliferation of ductal system is due to estrogen, and those of lobulo-alveolar system is the combined action of estrogen and progesterone. So ductal system is by estrogen, and lobulo-alveolar system is by estrogen and progesterone. So both the steroid hormones are required for adaptation of maternal organs to the constantly increasing demand of growing fetus. So all the physiological changes which are going to happen during pregnancy is majorly supported by the estrogens and progesterones. And progesterone maintains the quiescence. Quiescence means it decreases the myometrial contraction. So myometrial relaxation. It maintains a myometrial relaxation, and it maintains the pregnancy as well. Estrogen, it sensitizes the myometrium. It is having an antagonizing action from, if you see, it is having an opposite action to progesterone. Estrogen sensitizes the myometrium to oxytocin and prostaglandins. This happens in the later pregnancy, where the women usually enters into labor. And progesterone, along with HCG and cortisol, inhibits the tissue reaction and protects the conception. So progesterone is also having a immunosuppressive action. So these are the various functions of steroid hormones. So you can see in this chart, this red one shows HCG levels, where around 70 days, you can see this peak, 200 to 200 international units per ml. Then it is going down by 130 days. It is coming up to 10 to 20. And later on, it is constantly maintained in the second peak, if you can see at 32 weeks of gestation. So this is the graph of beta HCG. And this blue one, you can see this dark blue one is a human placental lactogen, which actually starts from third week of gestation. Progressively, it increases from 5 to 25 here. If you can see here, 5 to 25 micrograms per ml. And this light blue is a progesterone, and this green one is a estradiol. So these two hormones, steroid hormones, they have a progressive increase trend during pregnancy. So the next hormone is a relaxin. It has been demonstrated in human corpus luteum, decidua, and placenta. So it is released from decidua, placenta, and corpus luteum. It is structurally similar to insulin and IGF, insulin-like growth factor. So the rise in maternal circulating relaxin seen in early pregnancy is attributed to the secretion by corpus luteum, and the levels parallel those seen for HCG. And relaxin, along with rising progesterone levels, act on smooth muscles of the uterus to promote the uterine relaxation. So the various changes that happens in endocrine glands during pregnancy. So the major hormones which are actually secreted from placenta, we have read about placental hormones, which are actually actually maintaining the pregnancy and which are actually helping the pregnancy. And these are the various physiological changes that are going to happen in the endocrine glands during pregnancy. Coming to thyroid gland. So if you can see a thyroid gland, usually in pregnant women, there is slight generalized enlargement of the gland, which is due to hyperplasia, that is increased in cell. Because maternal serum iodine levels usually fall due to increased renal loss, because there is increased GFR and increased loss of iodine, and there is also transplacental shift to the fetus. So more amount of loss through renal or kidneys, and second one is more amount of iodine is getting shifted to the growing fetus. Thereby the iodine levels in the maternal serum gradually decrease. So iodine intake should increase from 100 to 200 micrograms per day. There is a rise in basal metabolic rate due to increased intake of or increased need of oxygen, both maternal and fetal. So if you can see a structural physiological change is slightly, the thyroid gland is slightly enlarged due to hyperplasia, but the women usually remains euthyroid. Euthyroid means the hormone levels in the maternal serum are normal, even though there is a structural hypoplasia or structural enlargement of the thyroid gland. Why this enlargement of thyroid gland is happening? Because there is increase in thyroid binding globulin. This thyroid binding globulin is a protein where thyroid hormone is going to get attached in the maternal serum. This thyroid binding globulin is increased due to estrogens. When this is increased, more amount of thyroid hormone is bound to thyroid binding globulin, and you can see the free hormones at a lower concentration. See, if the free hormones are at lower concentration, this will stimulate the thyroid stimulating hormone, which is going to get released from pituitary, and it will stimulate the thyroid gland, and finally thyroid slight hypoplasia, and again it will secrete T3 and T4. So when there is an increase in thyroid binding globulin, there is a transient fall in free T3 and T4, not the bound form. The free T3 and T4 decreases, and therefore increased production of thyroid hormones lead to increase in total T3 and T4, but normal levels of free T3 and T4. See, actually these free forms of T3 and T4 are metabolically active, and they are the active forms of thyroid hormone, which is actually necessary for the body to maintain the normal basal functions of the body. In pregnant women, due to increase in this thyroid binding globulin, where more amount of thyroid hormones are bound, and the biologically active free form is reduced. So to maintain that free form to the normal level, there is increased production of thyroid hormones. So if you check a pregnant women serum, the total T3 and T4 is increased, but free T3 T4 remains normal. And again, the second factor is placental HCG, as we have already seen in the previous slides. It is also a thyroid stimulator because it is having a thyrotropic activity also. So there is a transient decrease of TSH in the first trimester. If you can see, the fetal thyroid function usually takes place by 12 weeks of gestation. So thyroid gland usually structurally it is slightly enlarged with increased thyroid binding globulin and increased total T3 and T4. But if you can see the free T3 and T4 values, it is usually normal. So pregnant women are usually euthyroid, even though these structural changes are taking place in the pregnant woman. So coming to the next endocrine gland, the adrenaline gland. If you see an adrenaline gland, structurally there is an expansion of the adrenaline cortex and major of the zona fasciculata part of the adrenaline cortex. This is the major site of glucocorticoid production. And plasma levels of corticosteroid binding globulin rises due to increased liver synthesis. So where the thyroid binding globulin is also increased due to estrogen, here cortisol binding globulin rises due to enhanced liver synthesis. And free plasma cortisol level rises due to increased production and delayed clearance. So clearance is getting decreased and production is increased. And the various corticosteroid hormones like deoxycorticosterone rises due to fetoplacental unit, and DHEAS decreases. Testosterone is slightly elevated because increased sex hormone binding globulin and androstenedione. This parathyroid hormone, they increase progressively throughout the pregnancy due to lower concentrations of calcium, and parathyroid glands increase in size in pregnancy, causing an increase in this hormone and calcitonin levels. And calcium levels decrease in pregnancy, but ionized calcium, which is an main trigger for the parathyroid, decreases only slightly. This, coupled with increased glomerular filtration rate and increased fetal transfer of calcium, results in increased parathyroid level. So actually, the main stimulant of parathyroid hormone is ionized calcium, which is slightly decreased. But when this calcium, slightly decreased ionized calcium and increased clearance due to increased GFR and increased fetal transfer of calcium will reduce the maternal calcium levels, which actually trigger the parathyroid hormone, thereby increases progressively throughout the pregnancy. So calcitonin antagonizes the parathyroid hormone and vitamin D, and its level increases, which serve to preserve the maternal skeleton in times of severe calcium depletion, as in pregnancy and lactation. So PTH does not cross placenta, but calcium ions do cross against a concentration gradient. Thereby it reduces the maternal calcium levels, which actually acts as a stimulant to increase parathyroid hormone. The pituitary gland usually enlarges during pregnancy, but not it doesn't give the pressure symptoms, like it doesn't pressurize the optic chiasma, and various pressure symptoms are not seen. Usually it enlarges a slight little in pregnancy. And levels of almost all pituitary hormones, if you see the anterior pituitary hormone FSH and LH are low levels because of tonically elevated progesterone and estrogen level, which will help in negative feedback, and it will reduces FSH and LH. And prolactin hormone usually it increases tremendously, and this ensures lactation. And posterior pituitary hormone oxytocin, usually whose receptors and levels increases at the later trimesters in the pregnancy, late pregnancy, which helps in onset and progression of labor. So one clinical aspect is postpartum hypopituitarism, which we have called as Sheehan syndrome. It is directly related to hypovolemia. Due to postpartum hemorrhage, there is reduced blood flow and reduced volume in the intravascular compartment. So it leads to hypovolemia due to obstetric hemorrhage, accompanied by vasospasm of the pituitary vasculature. So there is a loss of anterior pituitary hormones, but the posterior pituitary hormone loss is uncommon, because this is majorly the posterior pituitary hormones are neuronal, but anterior pituitary hormones have a portal circulation where the vasculature is compromised, and thereby the hormones are not released. The patient after recovering from the hemorrhage, postpartum hemorrhage, usually present with failure to lactate and prolonged postpartum amenorrhea, hypothyroidism, and persistent hypotension. And she will need a complete replacement of all these anterior pituitary hormones. So pancreas, coming to the next gland is pancreas. Pregnancy is associated with hyperinsulinemia and insulin resistance. There is accelerated fasting hypoglycemia and prolonged postprandial hyperglycemia. And pregnancy is a diabetogenic state. If you see a pregnant woman in fasting state, it is associated with accelerated starvation. So this fasting state will lead to maternal hypoglycemia. Glucose levels are reduced in maternal serum, which will thereby reduce insulin levels and increases hyperketonemia. So due to diffusion of glucose by the fetoplacental unit. So major part of the glucose is transferred to the fetoplacental unit, and in the fasting state, glucose levels of mother is reduced and insulin levels as well, and it increases the ketone body formation due to fatty acid metabolism. So when she feeds, the feeding response is like increase in glucose levels, hyperglycemia, which will increase insulin levels, and hypertriglyceridemia, and reduces the tissue sensitivity to insulin. During the pregnancy, usually the insulin sensitivity is reduced. Why? Because there is a peripheral resistance to insulin due to human placental lactogen. As we have already said, human placental lactogen is having an anti-insulin-like action, and cortisol. Greater insulin resistance is present as the pregnancy advances. So endocrine control of lactation. Lactation is actually explained in 4 headings, like mammogenesis, that is the preparation of the breast tissue; lactogenesis, that is synthesis and secretion of milk by breast alveoli; galactokinesis is ejection of milk; and galactopoiesis is maintenance of lactation. First, preparation of breast, that is mammogenesis. Lactogenesis is synthesis and secretion of milk. Galactokinesis is ejection of the synthesized milk. Galactopoiesis is the maintenance of the lactation. So coming to mammogenesis, where we've already seen the ductal system is under the estrogen, and the lobular-alveolar system is under the combined action of estrogen and progesterone. So complete preparation of breast is called as mammogenesis, followed by lactogenesis. After the mammary gland is fully developed, with the withdrawal of estrogen and progesterone and action of other hormones like insulin, growth hormone, glucocorticoids, prolactin, these mammary glands will synthesize and secrete the milk, followed by galactokinesis, that is ejection of milk. And followed by galactopoiesis due to sucking reflex of the baby, and prolactin, which will maintain the breastfeeding, or which will maintain the milk secretion. So these are the major endocrine control of lactation, that is mammogenesis, lactogenesis, galactokinesis, and poiesis. So any doubts?